We begin the day with a case presentation by Dr. Winifred, a final year PG from ICH. To chair this session, I would like to invite Dr. Nirmala Natarajan ma'am and Dr. Meghalay ma'am on stage. Dr. Nirmala ma'am, Head of Department of Gastroenterology, ICH, is the perfect combination of book smart and street smart, with an unbeatable quick wit. Dr. Meghalay ma'am always seems as cool as a cucumber, with knowledge as vast as the ocean, which she is ever ready to impart to her students.
Vikash, 4.5 months old male child, who is second born of non-consanguineous parents residing at Mannarkudi, brought by mother whose history is reliable with complaints of yellowish discoloration of eyes and high colored urine since birth. History of present illness. The mother noticed yellowish discoloration of eyes and passing high colored urine staining diapers since birth. It was persistent and not progressively deepening. History of passing yellowish stools during initial few days of life, followed by clay colored stools. History of abdomen distension noticed by the mother more in the upper half and was progressively increasing in size. It is not associated with decreased urine output, edema or fast breathing. There is no history of upper GI bleed in the form of hematemesis, melena, or bleeding from any other sites, or history suggestive of skin bleeds.
Previous slide. So the mother noticed yellowish coloration of eyes. There is jaundice. Yes. Child, what was the age of the child?
Since birth, the mother noticed yellowish discoloration of eyes.
So the child comes with jaundice since birth. What is your idea?
Physiological jaundice mostly.
At birth. Well, it persist up
Day
to
one,
this age. So child is 4 months old.
Now so it is pathological jaundice. It's prolonged.
So you mean to say physiological jaundice, later on it became pathological?
Yes.
Okay. So what are the conditions you'll think, like jaundice starting from early in infancy and continuing up to 4 months? So what are the things you will think of?
If the child is well, I would think of cholestasis, surgical cause. If the child is sick, I would think of hepatitis, neonatal hepatitis syndrome, infective or metabolic.
Okay, so it is cholestasis, can be sick child, mostly you think of an hepatitis. A well child, you think of obstructive
surgical causes.
Something like a biliary atresia. Okay.
So why do you say there is staining of diapers? How is it important?
Due to the cholestasis, the bilirubin, the conjugated bilirubin is
the
diapers.
It's an important clue to find out that it's a
conjugated bilirubin.
Sometimes some mothers feel that when you give any vitamin drops, the urine can be colored high. Yes. So just to differentiate between it's because of any medications or it's only due to cholestasis, you try to ask the history of staining diapers. Very important history in the diaper. Okay. How important is the color of the stool?
Colored stools.
High colored urine will be seen in hepatocellular jaundice and cholestatic jaundice. In hepatocellular jaundice, the stools will be normal or pale, but in cholestatic jaundice, it will be clay colored. Initially, it may be yellowish, then in later days, it will be clay colored.
Progresses,
the obstruction is complete and pale. Clay colored.
So why the clay colored stools appears later?
Initially, the intestinal enterocytes, the epithelial cells shed, so there will be an yellowish covering for the stools. Later, the obstruction is complete. The total obstruction is there, so it's not pigmented.
You're partly right. It's a progressive disease. It may not be present at birth. So at birth, the child may not have the complete obstruction, as you said, but it's a progressive disease. Usually, most commonly, it's postnatal. So that's why initially the color may be normal, but later in some children even the jaundice develops later. This child maybe it's developed earlier. Most of children and obstructive causes jaundice may develop even later. Okay. So abdominal distension, upper half. So what do you mean by that?
If it is uniform, it might be due to fluid. It is the mother has noticed it's more in the upper half, probably due to organomegaly.
Then it's only upper half. Then why did you ask for oliguria, edema, or fast breathing? Tell me.
So usually when there is a fluid collection only you get all these problems. No.
So you wanted to rule out any fluid collection. Please. Okay, why did you ask for UGA bleed?
Portal hypertension if the child has developed due to this chronic
UGA
liver
bleed is all
disease.
for portal hypertension.
Yes.
And why bleeding from other sides?
Due to coagulopathy, if the child is
So bleeding in case of
developing.
cholestasis can be either due to coagulopathy or due to portal hypertension. So I have asked history for both.
The child did not have fever, lethargy, refusal to feed, or excessive crying during micturition. The child did not have cough or fast breathing. There is no irritable cry and no history of seizures. The child passes stools. There is no straining, and the stools are normal in consistency. The urine odor is not abnormal. The baby is gaining weight adequately, and the mother did not report any bleeding from prick site or a vaccine site swelling. Past history, initially the child went to private hospital at Trichy. There they found actress and they have to advised admission. The mother wants to get admitted at ICH, and so she came here.
You said abnormal urine order. What condition related to a condition like this? A child present with jaundice at 4 months of age. So what condition you want to rule out by the urine order? You said some.
Tyrosinemia. Will be boiled cabbage smell.
Okay, so when you think of a metabolic problems, you need to ask this question, right?
Antenatal history is a second conception at 32 years, spontaneous conception. Last childbirth was 7 years. She's registered and immunized. No history, first trimester, no history of fever, rash, arthralgia, painful posterior auricular lymphadenopathy, no history of exposure to cats, no history of jaundice, no history of drug intake. Second trimester, quickening felt at 5th month, no history of GDM, PIH or anemia. Third trimester, no history of excessive pruritus, no history of foul smelling liquor or draining PV. Antenatal scans, including anomaly scan, was normal, and the total weight gain during pregnancy was around 10 kg.
A child present with jaundice since birth and continuing up to 4 months. This history is important. Fever, history of exposure to torch infections, right? So what torch infections most commonly present as neonatal hepatitis?
CMV and rubella.
CMV, syphilis. So hepatitis infections are not that very common, but CME and syphilis can present as neonatal hepatitis. So we have to ask about torch infections in the antenatal period. Okay.
Birth history, the child was born by full-term LSCS, indication was previous LSCS, birth weight was 2.9 kg. The child cried immediately after birth, there is no NICU admission. The mother breastfed the baby within 2 hours of life. Child passed meconium on day 1. There is history of jaundice on day 2 of life. For this, the child was kept on phototherapy for 1 day, and then the child was discharged on 5th day of life. History of transition stools on day 5 of life. There is no history of total parental nutrition or exchange transfusion.
Why did you ask for history of total parental nutrition?
It will cause cholestasis, hyperalimentation. Developmental milestones are normal for the child. Diet history, the baby is on exclusively breastfeeding. Family history, the first child is 7 years, alive and healthy. The mother had an abortion spontaneous abortion at 2 months of gestational age, and this is a third conception. She has done family planning, no family history of liver diseases or infant deaths.
What are the conditions you thought of when you asked for family history of liver disease or infant deaths?
Autosomal metabolic conditions, autosomal recessive, tyrosinemia, galactosemia, hereditary fructose intolerance, alpha-1 antitrypsin deficiency, stick fibro.
What are the conditions which can run in families? The mother can have history of similar
Progressive familial intrahepatic cholestasis.
Yeah.
In that case, what symptoms can the mother have?
Mother will have increased pruritus, jaundice.
Yeah,
Right,
usually with PFIC 3.
Pre-
What other disease the mother can have affected the babies, which is fatal in the neonatal or young infancy if you don't treat it?
Neonatal hemochromatosis.
Yeah, neonatal hemochromatosis, which is otherwise called
Gestational
gestational
alloimmune
liver disease, GALD. Okay, yeah, that also. Okay.
Socioeconomic history, the family belongs to lower middle class, class 3 by modified Kupasamy scale. Immunization history, the child was vaccinated at nearby subcenter with 3 doses of Penta. Optional vaccines are not given. Contact history, there's no history of contact with open case of tuberculosis.
Now you discuss the case.
This is a 4.5 months child. This child is presented with yellowish discoloration of eyes and high colored urine with pale stools. The yellowish discoloration of eyes and high colored urine are since birth, and initially the stools are yellowish and then followed by pale colored stools. So it's a
Presenting with cholestasis.
cholestasis.
Okay, then?
This is a well child, term AGA baby, well thriving child, no significant perinatal history. So probably it is a surgical cause, probably biliary atresia.
So why do you say it's a surgical cause? So what is the birth weight to do with this?
In neonatal hepatitis, there will be IUGR or SGA babies will be there, and the babies will be sick, will not thrive.
Not thriving well. Okay.
This baby is thriving well, has no previous hospitalizations.
Okay.
So whenever a child comes with neonatal cholestasis, the first and foremost, the most important history is the color of the urine, which suggests from which you can find out it's cholestatic jaundice or not. The next most important is the color of the stool. If the color of the stool is totally pale, then most probably and persistent, most probably it could be due to surgical cause. What are the medical conditions which can present with persistent pale stools?
Insippisated bile duct syndrome.
That you cannot call it
Also.
medical, but maybe bile duct paucities. Bile duct paucities, one
Watson
condition which
allergy.
mimics surgical causes can present with pale stools. Okay, then so pale stools, and once the child is presenting with pale stools and persistent pale stools and eye colored urine, most probably it could be due to a surgical cause. And when the child is present with totally yellow stools, then it could be most commonly it should be only due to a medical cause. If the stool is light yellow, then it is a very difficult situation. It could be either because sometimes it can be lightly pigmented. Lightly pigmented stool is the most difficult to diagnose. It could be either medical or surgical cause. So this child has been persistent pale stools, clay colored, totally clay colored. So more favors a surgical cause. Okay, only if there is light colored urine, then you have a doubt it's a medical cause, surgical cause. Most probably it's a surgical cause. That's what with the history. Then the next one, if the child has got a yellow stool, then you have to think in terms either it's a sick child or it's a well child. If it's a sick child, then you have to think in terms of what are the conditions?
Torch infection,
Sepsis and infections and metabolic. Metabolic and sepsis and infection are the conditions where the child is usually sick. And when the child is well what are the conditions when the child is well in medical conditions?
Paucity of interlobular bile ducts, PFIC.
Okay, PFIC, relatively PFIC and
Allegilis.
positive bile ducts, relatively the child will be well. Okay. So with this, okay.
So what is the purpose of investigations? Why should there be an urgency in making the correct diagnosis and managing the child?
Biliary atresia means the child has to be operated within 60 days to restore the bile flow. There will be 80%
surgery will have better prognosis. Later
And also there are certain conditions which need to be identified, like if it is galled and all, you need to identify the condition, because something is treatable, certain things are treatable. So you need to identify those conditions which can be treated. Okay.
General examination, the child is alert, awake, alert and playful, looking around and making eye contact. The child is afebrile, there is no pallor, icterus is present, there is no sacral edema and no lymphadenopathy. Head to foot examination, there is no facial dysmorphism. The anterior fontanelle is 3 × 3 centimeters. The level is
with the person with facial dysmorphism and cholestasis.
Watson-Allergill syndrome, Zellweger syndrome, Down's.
Even hypothyroidism, no, you can have
Coarse facies.
Yeah.
Okay.
So these are the facial conditions which you have to look for. Yes.
Posterior fontanelle admits tip of finger. The
Posterior fontanelle is still not closed.
yes,
So what is suggest?
it could be due to vitamin D deficiency or hypothyroid. Hair is normal, icterus is present, there is no cataract and no signs of vitamin A deficiency, oral cavity is normal, skin there is no rash,
What are the
petechia,
conditions present with cataract?
galactosemia, oil drop cataract, congenital rubella syndrome. BCG scar is present, chest is normal, no umbilical hernia.
When do you see signs of vitamin A deficiency in an infant?
When the child is going for decompensated liver disease,
Karthi,
fat cell,
when do you see vitamin A deficiency? Ankit? Yes, maybe because their stores will be adequate, maybe they start manifesting after 6 months. Okay.
external genitalia is normal and limbs and spine are normal. Vitals are normal, anthropometry is normal.
That's normal, previous slide.
Head circumference is also normal. Systemic examination, abdomen, inspection, upper abdomen is distended, flanks free, umbilicus is pushed downwards and normal in shape. All quadrants move equally with respiration. There is no visible pulsations. Skin over the abdomen is normal. No dilated veins, scars or sinuses. Hernial orifices are free and external genitalia is normal. Palpation, abdomen is soft, not tender, no guarding or rigidity. Liver is palpable 6 cm below the right costal margins, firm in consistency, smooth surface, sharp borders, it's non-tender. Spleen is palpable 1.5 cm below the left costal margin along the long axis, firm in consistency and smooth surface, no other mass palpable. Percussion, liver span is 9 cm, there is no shifting dullness or fluid thrill. Auscultation, normal bowel sounds heard, no bruit or venous hum or friction rub. Other systemic examination, cardiovascular system, first and second heart sounds normally heard, there is no murmur.
What are the conditions you look for in cardiovascular system?
In Watson allegedly, there will be pulmonary stenosis, so there will be S2 split and murmur will be there in left third intercostal space. In congenital rubella syndrome, PDA will be there will be a continuous murmur.
Can
Biliary atresia have some cardiac problems?
Can they have?
Yes, biliary atresia, there may be situs inversus.
So biliary atresia also, one form of biliary atresia can present
With cardiac
anomalies.
Respiratory system, bilateral air entry equally heard, no added sounds. Central nervous system examination, there is no focal neurological deficit, bilateral pupil equally reacting to light. Diagnosis, 4.5 months baby who is looking apparently well with jaundice, high colored urine and pale stools. It's a case of neonatal cholestasis, probably surgical cause due to biliary atresia with portal hypertension and no ascites, no coagulopathy and no encephalopathy. With no malnutrition.
Well child with jaundice. The child is not well, you won't think of biliary atresia, is it?
The child is sick, I will think of neonatal hepatitis.
What I'm asking is this
Cholestasis.
persistent pain stools.
Child you said it
but
is
still it's
biliary
not thriving
atresia.
well. Still, do you think, in that case, will not think of biliary atresia? Asking.
Pale stools and
Even biliary atresia can present with failure to thrive. When will it present failure to thrive?
associated malrotation, cardiac anomalies, BAS,
What type it is?
biliary atresia with splenic malformation, BASM. There the child will be failure to thrive.
Embryonal type or the prenatal onset type, they might be even small for date and they might even failure to thrive. Only the postnatal onset, the child will be well. So it doesn't mean that the most important is only the correct too. Why do you say it's portal hypertension?
The child is having spleen, so I thought of portal hypertension.
Normally in biliary atresia,
Normally, the spleen will appear little late.
so biliary atresia is not a part of biliary atresia. Splenomegaly is not part of the disease. Usually splenomegaly develops only due to portal hypertension. That means the child has going in for
portal
cirrhosis. So this child may be going for that's why you have a
Splenomegaly.
Otherwise, hepatosplenomegaly, what other conditions you think of? So otherwise, this child did not have a pale stools, it had only a light yellow stools. Child has got hepatosplenomegaly. So what are the conditions you think?
I'll think of torch infections,
First thing is torch infections, yes.
sepsis,
Sepsis,
infection.
hepatomegaly. It's quite a big one, no? 6 centimeters.
Metabolic diseases affecting liver causing portal hypertension, producing splenomegaly. Storage disorders, gout, Niemann-Pick.
Because this child is a well child, only hepatosplenomegaly, so you have to think in terms of
Storage disorders.
Other than the
also.
pale stools, if the child did not have pale stools, then you have to bring in even a
Storage
disease in the
disorders,
dead.
Niemann-Pick.
So what is storage disease can okay.
Niemann-Pick, gout, Ullmann. This child, the basic investigations, CBC has to be done. Then LFT has to be done, which we conjugated or unconjugated bilirubin. Stool macroscopic examination for 3 consecutive days has to be seen to look for the.
Why do you do that?
There is complete.
Why on 3 consecutive days you want to see?
There is.
Why?
Due to complete obstruction, there will be no pigmentation.
Okay, that's one. Once
3 days.
today, there's no pigmentation. Why do you want to see tomorrow? Karthi? Anyone else? So bile secretion is generally intermittent, and even one pigmented stools rules out biliary atresia. So that's the reason we keep seeing at least for three consecutive days, and you have to see it by yourself. Do not believe the mother, because mothers will not. The normal color of the stool, mother may not know, especially the first
in
child.
children who are with all the nappies. Sometimes the color of the urine itself
Actually,
will
it gets
stain the
on.
stool. So you need to see the stool
Actually, you
by
ask them
yourself.
to
Cut
collect
stool.
it in the bottle and then see. Only then you'll be correct color. Okay, it's most important. Okay, very good. Next.
Ultrasound abdomen after liver function test.
How is it
Bilirubin.
going to help you?
First, we should see whether it is conjugated cholestasis or not.
Clinically, we know that's only
Conjugated. Synthetic function proteins has to be seen, whether the liver is get affected or not. OTPT has to be seen.
OTPT, how is it going to help you?
If the OTPT is in racing time, it is going for necrosis.
No, whenever the OTPT is raised, it shows that there is necrosis. Okay, that is okay. Then how is it help? So, what's the purpose?
In
of doing,
hepatocellular.
I'm asking, what's the purpose of doing these tests?
To differentiate hepatocellular and cholestatic jaundice.
How will you differentiate?
OTPT will be more raised in hepatocellular jaundice and not in cholestatic jaundice. And
it's not reliable, but very high enzyme, then more favors hepatitis rather than obstructive cause. That's all. But that is not a reliable test. Only if there is a protein is low, then you know the child is going for
decompensation.
Nothing. So, what is more important? Which enzyme is very important?
GGT is more important.
So, how is it important?
It is secreted by the biliary canal. It is.
How is it important? In cholestasis, how is GGT important? Your diagnosis is going to be based on your GGT.
So what are the conditions in which
It is
elevated?
normal and where it is elevated.
Where it's low.
Progressive familial intrahepatic cholestasis, GGT will be raised in PFIC 3.
In all the PFICs, it will be elevated.
PFIC 1 and 2, it will be normal. PFIC 3, it will be elevated.
Okay. Any other condition, it will be low.
If the by paucity of
No, when there is a problem in bile acid synthesis itself, synthetic defects also is going to be low, right? Okay.
That's why we do both bile acids and multitudes.
ultrasound abdomen after 4 hours of
Prothrombin time also is part of liver function.
PTINR.
Next.
USG abdomen to see the after fasting,
Why do you want to do the ultrasound on milk-free diet?
so that the gallbladder will be distended and we can visualize gallbladder.
Okay.
We should
Fat,
give
What are
whenever
the
you
other
fat,
things you will see in the ultrasound abdomen which can help you in the diagnosis?
cyst, presence of cyst.
Yeah, choledochal cyst, yes, then
the main purpose of ultrasound is to rule out condition other than
On
biliary
mother.
may not be diagnosed by ultrasound alone. But the main purpose to rule out other surgical conditions can be diagnosed very well by ultrasound, like choledochal
Strictures.
cyst, bile duct strictures, and choledochal stones. Choledocholithiasis.
Cholelithiasis.
Very easily diagnosed by ultrasound. That's the reason we are doing ultrasound and to rule out other surgical causes. So, how will you? Can you confirm biliary atresia by ultrasound?
No, ma'am. Can't confirm.
Okay. So, what can you do? Then what's the purpose of doing it?
It is a non-invasive. We can do it in the next day of admission, so we can get an idea.
The only thing is you can rule out biliary atresia whenever the gallbladder is distended well on fasting, and once the child is fed completely empties, you can to a certain extent you can
Rule out biliary atresia.
but you cannot confirm biliary atresia by ultrasound. What are the specific features we look for whenever the suspect biliary atresia? What will ask the sonologist to look for on ultrasound?
Triangular cord sign.
So what is the triangular cord sign?
The right portal vein anterior wall will be thickened. 4 millimeter thickness will be then triangular cord sign and ghost triad sign. Irregular contour of the gall. Triangular
but
cord
these are all
sign.
why we are not picking up all these things.
so depends on the observer.
So observer and it needs a high frequency probe which may even this
May not
time
be available in all
may not be
centers.
picked up by routine ultrasound. That's why we are not able to pick up. Okay. So
Then-
when will you do IDA?
If the
Will you advise IDA for all children?
no, ma'am. If the stool is
This child will you ask for IDA?
no,
Why?
the stool is pale. It is not
When it's
pigmented.
completely when it's
Clay colored, so not.
really white, na, then you need
No,
not
not
know
the-
we know that there is no bile coming out. So the IDA may not be useful. Only when there is a doubtful,
Doubt-
when there is a lightly pigmented stools, when you're not able to differentiate between obstructive and cholestatic causes, other cholestatic causes, then you'll have to do a HIDA. Otherwise, when you're definitely sure that this only a biliary atresia, that's with the persistent pale stool, then you need not do a HIDA. So what's the purpose of doing HIDA? How does it help you?
We can see whether the biliary system is intact or not. If there is a good uptake over the intestine, if there is good uptake in the liver and excreted over the intestine, we can. It rules out biliary atresia if there is.
For excretion into the intestine, the excretion is there, then it rules out biliary atresia. When the excretion is not there, still you cannot say it's only biliary atresia. It can be other kind, but once it's excretion is
Yes,
there
sir,
in the
it's
intestine,
rules
you
out.
definitely know
Rules
that
out.
it's not biliary atresia. That's the only thing. You can definitely rule out biliary atresia by HIDA.
Any other condition, there will not be any excretion into the intestine, but it is not biliary atresia.
Choledochal cyst, insipid bile duct syndrome, there will be plugs obstructing, could not be excreted.
Certain other conditions also, when there is severe intrahepatic thing like an alagallase syndrome, alpha-1 antitrypsin, you can sometimes get no excretion into the
Paucity of
intestine,
bile
but it
duct,
is
so we
still not biliary atresia. So you can have false positive conditions also. So what is the gold standard test you will do?
Peroperative cholangiogram is the gold standard.
What about liver biopsy? Why didn't you have liver biopsy in
Yeah, it's not there.
in your algorithm? Give the answer. Why this child? Why you don't want to do a liver biopsy? You have a valid reason. Why you
This child is having clay colored stools. It is biliary atresia.
This child is old, almost becomes 4 months old. So now the child, and we know that there is evidence of portal hypertension in the form of splenomegaly. So this child has gone in for cirrhosis. In the Mari child, it may not be useful. It may not be useful to do a liver biopsy. When the child is presented before
Earlier.
60 days, liver biopsy is the ideal test to do. Definitely, liver biopsy can differentiate between urinary hepatitis and biliary atresia, but done early. So that's it. Because the child is presenting late, this child may not benefit from a liver biopsy. But otherwise, the child is going to present before 60 days. Definitely, liver biopsy should be there before your paraprotocol angiogram. In the hands of a good, the experienced pathologist, definitely we can differentiate between biliary atresia and urinary hepatitis on. So what will you look for on biopsy? Biliary atresia, what will you look? What will you see? And it's going to be hepatitis. What will you see?
Proliferation of bile ducts will be there. And periportal fibrosis will be there in biliary atresia. In hepatitis, there will be necrosis. Multinucleated giant cells will be there in liver biopsy.
So this child, yes. So this child you're going for a perioperative cholangiogram. So how will you do it? Otherwise, how is it done?
Under anesthesia, it's an procedure. The surgeons proceed with the dye to check the intact system of biliary system. If it is not intact, then they'll proceed with Kasai.
Where do you inject the dye? Should have asked at least Venkat or someone. Where do you inject the dye, Venkat? Karthik? So you have to inject the dye into the gallbladder. So you have to, sometimes it will be very attractive, totally complete. Then you know that's only biliary, so you don't have to inject dye, but otherwise you have to inject the gallbladder and look for excretion in the intestine. The intestine excretion, you know that it is not biliary, so you close and come, take a biopsy and come. If there is no excretion, then you have to look for a proximal also. Distal, you just clamp and then look for proximal excretion also. Proximal was not there, you know that definitely both intra and that. Why do you want to do even? Why do you want to look for a proximal also?
In type 1 biliary atresia, there will be proximal atresia that will be correctable.
Then that's a good,
We can remove
surgically correctable form of
easily
biliary atresia, which will do well with surgery. That's why you want to find out it's okay. So once you know this biliary, confirm that biliary atresia, then you proceed with the
Kasai.
Kasai. Okay, now we next slide.
This is
Okay,
for
now
other.
this child you have done perioperative cholangiogram. There is dye excretion into the intestine. So what are you going to do next?
It rules out biliary atresia. It will then we will look for other causes of cholestasis. Other workup has to be.
What are the causes for cholestasis? No. What are the causes for? Discuss all the causes for cholestasis.
Intrahepatic, extrahepatic. Intrahepatic infections, toxoplasma rubella, cytomegalovirus, syphilis, tuberculosis, herpes, bacterial, metabolic gout, carbohydrate metabolism, gout, galactosemia, hereditary fructose intolerance, protein metabolism, tyrosinemia, lipid metabolism, Gaucher, Niemann-Pick and Wolman's, endocrine, hypothyroid and hypopituitarism, familial, paucity of intralobular bile ducts, Watson-Alagil. Syndromic is Watson-Alagil. Non-syndromic, it could be stick fibrosis, alpha-1 antitrypsin deficiency, congenital rubella or congenital CM infection. Familial Agenus syndrome, PFIC, BRIC.
So what are the common metabolic disorders which present at birth, which we see in our hospital?
Galactosemia.
Galactosemia, okay.
Tyrosinemia.
Because you have not seen doesn't mean it doesn't present. Tyrosinemia, galactosemia, even hemochromatosis we have seen.
Neonatal hemochromatosis.
These are the common conditions which you see in our part of the country. So how will you diagnose these conditions? When will you suspect and how will you diagnose?
Galactosemia, the child becomes sick immediately after feeding. Some child may present over the 1 week later with jaundice. There will be failure to thrive, vomiting, shock, it will present. So
Seizures.
seizures present. RBC galputus, urine for reducing sugars is seen at first. Then the confirmatory is RBC galactose 1-phosphate enzyme study. It will be deficient.
Is cataract a must in all cases with galactosemia when they are present in the newborn period?
It will present a little late due to the accumulation of galactitol in the eyes.
Yeah. So you may not find a cataract at the immediate neonatal period.
What is the diagnostic test for tyrosinemia?
Urine, initially alpha fetoprotein we will do, then we will proceed with the urine succinyl acetone or succinyl acetate will be done.
How will you confirm neonatal hemochromatosis?
Mucosal biopsy, we will do ferritin first, it will be elevated.
Where do you take usually? Mucosal biopsy?
Buccal,
So, buccal mucosa. Lip usually.
Any other test you can do? Does MRI help in these children? MRI? Hemochromatosis. MRI of the pancreas, MRI of the cardiac. So T2 weighted images decrease intensity. So it is this extra hepatic iron will be there, extra hepatic cirrhosis. So MRI is helpful.
So etiological approach.
For other child who is presenting the cholestasis and sick, we should rule out sepsis first. Blood culture and urine culture has to be done. TOT screening has to be done. Hypothyroid causes cholestasis, so TFT has to be done. This is correctable cause. Urine metabolic screening is done for galactosemia. Serum bile acids is done. The bile acid synthesis defects pathology has to be thought. To rule out that, serum bile acids has to be done. Serum alpha fetoprotein and urine succinyl acetone are done for tyrosinemia type 1. RBC galactose 1-phosphatidyl transferase is done for to diagnose galactosemia. Bone marrow examination is done for Gaucher's and Niemann-Pick disease. Sweat chloride test is done for cystic fibrosis. And TMS is done for inborn nerve metabolic.
Okay, this child, you've done an operative cholangiogram. So it's suggestive of biliary atresia. Will you proceed with the surgery? I mean, Kasai, or what will you do? This child is 4 months old.
If the child is having type 1 biliary atresia, we can proceed. If it is
what are the types of biliary atresia?
3 types are there. Type 1, the proximal CBD is atretic. Here the success rate is good. We can anastomose CBD with the jejunum. And type 2, 2A and 2B are there. Here the distal part of CBD with the right hepatic and left hepatic is atretic. In type 3, the entire IH, intrahepatic and extrahepatic is atretic. This is the most common type and with poor prognosis. In this child, Kasai will not be useful. It has crossed 4.5 months. So restoring bile flow will be.
So when do you say Kasai is successful? Kasai surgery is successful. What is the criteria for say?
It should be done within 60 days to restore the bile
but
flow.
When will you say a Kasai is successful?
Post-op, 6 weeks after post-op, the bilirubin should decrease.
Normalization of the
bilirubin.
6 weeks or 6 months?
6 weeks.
Okay. So what are the factors which affect your success in Kasai?
Age of the child.
Okay. Age at surgery, right? Yes. On the type of biliary atresia and the extent of liver damage at the time of surgery and the experience of the center that is doing the procedure. So these are the things. So what are the common problems these children will have following surgery?
Surgical failure, the child still will be having cholestasis.
Okay, not successful. So what do you do if the child is having a failed Kasai?
Liver transplantation.
Liver transplantation. Okay. So, okay, it is successful, but they have some problem.
Infection.
Ascending cholangitis. That is a common problem these children will have. Okay. Yes.
Successful Kasai, will they require transplant?
No, ma'am.
Still they will require.
Yeah, it is an ongoing process.
Later
so
maybe.
It is an ongoing process. The inflammation and fibrosis is ongoing. So about 70% of them, even after successful Kasai, will need a liver transplant at a later age. Okay. So what is the purpose of doing the Kasai? It is only to buy time. So buy time. So it is decompression and bile drainage till you can
do
plan a liver transplant. So it is just buying time.
What do they do? Kasai, what do they do?
Roxanne by anastomosis is done. The baby's small intestine is taken as a conduit and bile flow is restored from the liver to intestine.
So we are expecting that bile flow will be restored because we think there will be some disconnected bile tubules inside the fibrous cord that can drain, but that doesn't happen always. That's the reason there is failure of Kasa. Okay. So how will you manage this child? This child refuses surgery. They say, I don't want surgery. So how are you going to manage the child?
Supportive therapy, nutrition, I'll prescribe 125 kilocalories.
It's common for all cholestasis, irrespective of surgical or medical. The management is common. Okay.
Nutritional requirement 125% of kilocalories has to be given. Proteins 2 gram per kg. Vegetable proteins has to be given.
This child is 4 months old. What are you going to give this child?
For this child, I will suggest breastfeeding with fortified with Smile MCT oil, 1 ml per kg per day. And vitamin A, D, E, K. Vitamin A 25,000 international units per day. Vitamin D 800 international units per day. Vitamin E 400 international units per day. Vitamin K 5 mg IV once a month. Water soluble vitamins twice the required daily allowance. Calcium 100 mg per kg per day. Phosphorus 50 mg per kg per day. Zinc 1 mg per kg per day. Magnesium 1 milliequivalent per kg per day. Vaccines, if the child crosses 1 year, hepatitis A vaccine suggest, and optional vaccines, pneumococcal vaccine and annual influenza vaccine suggest.
What are the problems you expect in this child? Now the child is not going for surgery. So what are the problems you expect in this child?
The liver will get fibrosis. The child will go for decompensation, and the child will get portal hypertension. It will
GA bleed, hepatic
by 18 months it will.
So what do you do for pruritus, ma'am? So now the child does not have any pruritus, well child. But
When will the child develop pruritus?
More than 6 months, initially itself pruritus will be there.
Why there is no pruritus initially? Why it appears later?
Initially also there will be pruritus. The child will be manifesting by cry.
Child cannot itch, but there is the sensation. Okay. So manifest like?
After 6 months, the child will scratch, and scratch marks will be there. We can find pruritus.
So how will you manage pruritus?
Utka,
Cause of pruritus.
the bilirubin, the cutaneous itch receptors are stimulated by the
Actually, it's not known. Not well understood. Okay. It's not understood well, but anyway, bile acids one of the
Bile acids.
thought of, but it's not true. Okay, then. So how will you manage? That's why it's difficult to manage the pruritus. We don't know what's the cause. That's the reason it's difficult to manage. Okay, tell me what will we try generally?
We will give Utka, rifampicin or opioid antagonist, cholestyramine are also tried.
Why do you want to give Utka? Why do you want to give cholestyramine? Why do you want to give phenobarbital?
Utka is hepatoprotective. It will remove the toxic bile salts, and this bile salt will replace it. So we are giving Utka. Phenobarbital is used glucuronide transferase conjugation. It will eliminate. Not eliminate.
No, improve the bile flow.
Bile flow.
So they
They're
improve
all
the bile
choleretics
flow.
basically, no?
That's the reason. So there's improved bile flow. No? There is accumulation of bile salts is prevented. That's the reason. That's what thought of. Okay, it's not because it's hepatoprotective. Hepatoprotective is another which helps. But this is not the reason why we give phenobarbital and Utka in case of pruritus. Okay, then what are the other drugs which can be used for pruritus? Fast.
Cholestyramine.
Cholestyramine, why do you give?
It is it's an absorbable resin. It will bind with the bile acids and cholesterol and eliminate them in the feces.
Then what else?
Opioid antagonists are tried. IV naloxone or oral nalmefene is used because there is increased opioidergic tone.
Are we using opioids?
No.
So what else we are using?
We are using Utka, cholestyramine, rifampicin in intractable cholestasis. Phenobarbital we are using.
Rifampicin has got dual action, so it's useful.
okay, any other thing you can do for pruritus if it's very disturbing?
What are the conditions where the pruritus is very, very disturbing? What are the conditions?
PFIC.
PFIC. Another one? Alagli also. So PFIC and alagli, it's really disturbing. So what will you do? How will you help them? Time over போக முடியாது சொல்லிட்டு
Colorectal agents only.
Biliary diversion, no. Biliary diversion.
Biliary diversion surgeries are beneficial for them.
Biliary diversions can help. Only thing, condition that should not be cirrhotic. This
So any of these conditions have any specific treatment? So you said all these are, you're doing all these investigations to find out some causes. Are there any conditions where some specific treatment can be offered to the child?
For sepsis, we will treat with antibiotic. For thyroid, thyroxine will
Metabolic.
galactose-free diet has to be given. For tyrosinemia, nitisinone is given.
And for GALD, what do they do?
IVIG in the
Now, you have to do transplant only. Okay. Any other questions you have? You want to clap? Thank you.
Thank you, ma'am.